So hi everyone, hope everyone is well. My name is Dr. Lasker. Thank you so much for joining us today on this talk. Got quite a few people turning up, so it's always very encouraging that people are still interested and hopefully going to learn something altogether. So I'm going to open up the chat function, and so that I'll be able to kind of keep tabs of what people are asking, and I'll also keep the Q&A in case people want to ask any separate questions. And in the meantime, I'll also, I think we're going to give you the link to the actual cases. So apologies if it doesn't load up straight away. I do understand there's been a couple of technical issues, but in the meantime, I'm just going to go through the cases off my computer, and hopefully we will still be able to learn a few things together. So what I'll do now is just share my desktop, and let's open up this case here. So hopefully it opens up across. No, let's go. That's a bit too soon. Let's go for something not too difficult straight away. Okay, so what we'll do is open up this one. Okay, so we're looking at this CT scan, okay, and what I'll do one scroll through, because obviously I do understand that not everyone has access to the cases right now, and just see what you think is going on. And what we'll try and do is just write in the chat description what you think is happening. I'll try and answer them as best I can. So this is clearly a CT scan of an adult patient, and we can see that this is a contrast enhanced study because there's a fair bit of there's some contrast sitting over here that looks very, very bright and white. So that must mean that we're kind of what looks like an arterial phase, but also we've got a bit of contrast sitting within the pulmonary vessels as well. So therefore, this would kind of, sometimes you get like a combination of the two. It's not because we've done a dual phase, it's just the luck of the draw. So at first, on first impression, we can see that there is what looks like bilateral pleural effusions, right? Quite large bilateral pleural effusions. And at first you think that, oh, maybe there's a pericardial effusion that is sitting over here. And actually there is some fluid around there, but it doesn't look like it's quite within the region of the pericardium, because you can still see there's a little bit of fat between there. So I'm not sure it's within the pericardium. It might actually just be fluid associated with the mediastinum. So you think, okay, great, you got some fluid that's in the mediastinum, not a big deal. Now let's go to the lung windows, and we can see that there is what looks like a lot of breathing artifact. And for those that don't know what breathing artifact looks like, it's where you can't really see the entire continuation of the vessels all the way through. They kind of look like little swans, as it were, rather than like straight vessels like that. And that usually happens because the patient's very, very breathless, and they have been able to hold their breath and the lung hasn't stayed still. And you kind of get this sort of fluttering appearance to the lungs. And you can see in these regions over here, can you see these all look like seagulls, kind of, they're not quite that sort of linear straight appearance that you'd otherwise get. But okay, so now when you come down to this area, we can see here that there looks like some collapse of the lungs. So there's a lot of fluid and it's kind of causing the lungs to sort of collapse in on itself. And then you can see maybe some air bronchograms within there. And for those that don't know what that is, I'll explain that to you guys in just a second. But it basically is consolidation. So this whole thing's kind of collapsed on itself. And that can happen because of the pressure, because of the pleural effusion. So you'll see that very, very commonly when you've got large pleural effusions, and usually within the lung bases, right? So the next thing to do is obviously just have a look at the upper abdominal organs just to make sure they're okay. And you can see this kind of bright linear thing that is sitting along this region over here, going all the way down into the stomach. And that is an NG tube. And it's quite important just to make sure it's adequately placed. And it's quite far down, actually. It looks like it's right in the region of the pylorus. So generally speaking, you'd want it to be a region in the fundus of the stomach or in the region of the greater curvature rather than all the way down. So they might want to pull it back depending on the clinical symptoms. So if I go to this particular slice, is there anything that makes you particularly concerned about what's happening here at all? If you do find anything that you'd be concerned about, then do throw it in. If not, don't worry. I'm going to quickly talk about something else in the meantime. So hopefully this works. I have got a fancy new piece of equipment where I'm going to try and illustrate to you guys what is happening when you're looking at lungs on CT. So first off, you've got like your airways, which look like this, right? And can you just let me know if people can't see the pictures I'm drawing? So you got your kind of airways that go like this, and they almost sit like within sort of cylindrical area, right? So let's say that's the airways, right? That's where, or that's basically like a straw. And then around it, you're going to have like the container where all the air goes and it kind of dissipates around and stuff like that, right? Then this glass is essentially made of blood vessels and lymph. And you've also got an accompanying blood vessel going along like this as well. So when you've got a lot of fluid, right, what ends up happening is that it's just like having a cup of water where the straw doesn't get full. So that's what you'd have when you've got consolidation, right? So consolidation would be this cup full of water, but the airway is actually maintained all the way along. But then if it becomes cloudy, rather than being actually fluid filled, then it's going to be like dot, 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 dot like this. And that's where you get these ground glass appearances, right? So then what ends up happening is that when you've got this big consolidated changes, you can see the air bronchogram. And that's what we're seeing on that very sort of basal image, right? So now when we go back to the CT scan, a few people have said right side pleural thickening with associated moderate pleural effusion. So people have said that there's pleural thickening, which is not a bad shout. I assume you're talking about, well, I guess it's going to be this area over here, yeah? So you may have noticed that, some of you may notice anyway, that there is a bit of a difference between the density of this area compared to this density over here. This looks slightly lower density and this looks slightly higher density. And actually it looks like it's tracking along the oblique fissure and all the way down. And there's a very definite difference between the densities of the fluid that is located within that hemithorax. If we look at the other side, you can almost see, yeah, there is a difference between this area over here and this area over here. This area looks a bit more hyper dense compared to this area over here, which doesn't look as dense, right? So therefore, you've got to start being a bit concerned. There's more to this story than just a pleural effusion. Now, it's something to be aware of is sometimes you can have some artifact from maybe the arms being up. Sometimes the arms are being put right across here, and that can result in anything immediately behind the arms looking a little bit more hyper dense than they should. But this is very, very far away from the arms. It's almost uniformly hyper dense all the way down. So yes, it could be. It could very well be some soft tissue thickening, right? It does look a little bit lobulated. But the other thing is that in the context, if it's something like trauma, then you've got to be a bit concerned that this could be underlying hemorrhage. And so therefore the clinical history to be. I don't know how I muted myself, so I'm going to start again. So the thing is, you've got hyperdense material that is located within this region. And so therefore, you've got to be concerned, is this soft tissue or is this sort of hyperdense fluid, i.e. blood, right? And then you've got to really start looking around, seeing if you can see any rib fractures or anything like that. And I can't see any rib fractures, but you can see that the mediastinum has had a previous sternotomy, but it doesn't look particularly like there's callus formation around. It looks like a very recent sort of procedure. So actually, this is most likely to be a recent procedure that has happened. And actually, when you look at the neck over here, can you see there and there is what looks like a line that's going right into the sort of SVC. So clearly this patient's unwell, most likely have had recent cardiac surgery, which is why you've got a lot of fluid located within the mediastinum. And actually, as you come further up, you can see there's multiple clips located associated with the mediastinum as well. And you've got this hyperdense material located within the pleura. So I thought this is an interesting case because it illustrates quite well how at first glance, when you go through it, you think, pleural effusion, cardiogenic failure, big deal. But actually, when you look at it a bit closer, you can actually see, yeah, you know what, there is a difference between that density there and that density there. And that's where you've got to start being worried. Now, the big question is going to be, is this patient still bleeding? So you've got to scroll through and really try and make sure that you can't see any sort of bright blush located within that pleural area. Because if there's that bright blush, then you're thinking that, okay, this could be an acute and ongoing bleed. But I don't think I can convincingly see that there is anything like that. Now, let's say you said that there's a big hematoma located within that region. You haven't seen any active bleeding or anything like that, but the patient's still quite unwell. So the other thing to do is just make sure that you've had a look at everything else to make sure there's no other area that the patient could be hosting blood from. But you may end up just having to go to the interventional radiologist, who will then have to basically live inject some contrast into the patient, see if they can identify any potential points of bleeding. I don't think on the CT scan you can be so sure that there's any point of bleeding there. Right, so yeah, well done everyone. I think people have done quite well with that one.